Hello everyone. As a part of continuous cardiac education, our topic of discussion today is lipid management by Dr. Riaz Charania sir, who is assistant professor in cardiology department at UN Mehta Hospital and having 6 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Hi, good morning everybody. I am Dr. Riaz Charania. I am an assistant professor in cardiology at UN Mehta Institute of Cardiology. And today I'll be discussing about lipid or cholesterol management and their guidelines. So essentially across all the individuals and in all the patients, we do emphasize a healthy heart lifestyle. So the diet and exercises are the key stones on which the guidelines are based on. So the first and foremost is a healthy lifestyles, which helps in reducing the development of risk factors and is the foundation of ASCVD risk reduction. Now, ASCVD means atherosclerotic coronary vascular disease. So we'll come to the secondary prevention in the lipid management. Secondary prevention means it's the prevention of another attack or another event from happening in patients who have an established ASCVD event. Now, what do you mean by ASCVD events? That's like the patients who have suffered an myocardial infarction, a stroke, or a peripheral vascular disease. So why and what was the need for secondary prevention? So secondary prevention, the recurrence rate of any cardiovascular event was within 1 year of an MI was 50% and within 3 years of myocardial infarction was 75%. So the recurrence rates of events of cardiovascular event in patients who already suffered an event is extremely high. So there is a need of preventing these high secondary events, and these events are especially higher in the patients with very high risk. So these are the major ASCVD events which have happened, like recent ACS or a history of MI, a history of ischemic stroke or a symptomatic peripheral arterial disease. These are the patients who are at a very high risk of recurrent events in a very short duration of time. And then there are certain high risk conditions, like in patients with age of greater than 65 years, a patient who had a prior PCI or bypass surgery, and the patients with diabetes, hypertension, CKD, who are smokers and who have an persistent elevated LDL cholesterol levels. So it's even defined in the guidelines by ACC-AHA that very high risk of an ASCVD event to include the true secondary prevention patients which has 2 ASCVD events, that is a history of ACS or an MI, CVA or a symptomatic PAD, or the patients who have suffered from one major ASCVD event with 2 or more high risk conditions which I had already mentioned. So these are the patient subgroup which are considered under very high risk population by the guidelines. So what do we have in our armamentarium? So the first and foremost drug which we have, which has been studied over many years in the past, is statins. Now statins, they do have a role in LDL cholesterol reduction. They are HMG coenzyme A reductase inhibitor, but they have pleiotropic effects, that is, they help in reducing the platelet activation, they increase the endothelial progenitor cells, they have their effects on collagen, they have their effects to reduce the inflammation, reduce the immunomodulation, and there are multiple effects which are actually helpful in not only reducing the LDL cholesterol, but there are another benefit of giving statins. So how do we divide these statins? So the statins are divided into high intensity, moderate intensity or low intensity statins. High intensity statins are the ones which reduce the LDL cholesterol by greater than 50%. So these include atorvastatin of 80 milligrams or 40 milligrams and rosuvastatin of 40 or 20 milligrams. We have moderate intensity statins which reduce the LDL by 30 to 49%, and here will include atorvastatin 10 milligrams, rosuvastatin 5 or 10 milligrams, simvastatin 20 to 40 milligrams, and we also have fluvastatin, lovastatin and pravastatin. Most commonly used among these is atorvastatin, rosuvastatin, and we do use pravastatin and fluvastatin or pitavastatin when the low or in some statin associated side effects we do consider these drugs. So in clinical practice, ACS patients should receive long-term intensive lipid lowering therapy. It should start with a statin irrespective of their baseline LDL cholesterol levels. And these ischemic events which are recurrent in ACS patients, they are higher in ACS patients compared to those who have a stable F angina kind of disease, and this risk varies with this baseline LDL levels. LDL lowering has been proven to prevent MACE, that is major adverse cardiovascular events. The 10 years risk of major adverse cardiovascular event in ACS is 40%. So we advise to initiate statins early and in high intensity in these patients. So this is a chart which was given in the guidelines. As I already mentioned, the healthy heart lifestyle is the first thing which should be advised to each and every patient, and for the patients which are at a very high risk or which are not actually at very high risk but still they have suffered from an ASCVD event. In both these subgroup, basically it says to start with a high intensity statin, and that is a class 1 recommendation. Now you follow up these patients, and after say around 3 months you repeat the lipid profile in them and check the LDL cholesterol levels, and if the LDL cholesterol levels are still high, that is greater than 70 milligrams per deciliter, you think of adding another line of agent. Most commonly used drugs in this second therapy is ezetimibe and PCSK9 inhibitors if the LDL cholesterol levels are still higher even on ezetimibe. And if the patient is not a very high risk and a patient population is a slightly older age, that is greater than 75 years, you can still consider, according to me, giving a high intensity statin. If they are tolerating it well, it's good, but if they are not tolerating high intensity statin, you can go for moderate intensity statin. So this is another chart which shows that apart from statins, you have ezetimibe, which inhibits the cholesterol from the gut. It has its action in that way, and it helps to reduce LDL cholesterol another 15 to 20%. And then there are PCSK9 inhibitors which help to reduce LDL cholesterol level by another 60% over and above what was achieved by statins. So now we go towards primary prevention. Now whatever I had talked about early initiation, high intensity statin therapy was for secondary prevention, that is the patients who have already had an event. Now primary prevention per se is for those who have not have an event before, and these are again subdivided into 3 categories. Now the first category of patients here are the ones where LDL cholesterol is greater than 190 milligrams. So 190 milligrams, these are the patients generally who have a genetic disease, homozygous or heterozygous familial hypercholesterolemia, and in them you have to initiate a high intensity statin right away irrespective of the age. The next patient subgroup what we have is the patient with diabetes mellitus and with the age group of 40 to 75 years. Now here you have to reduce absolute event rates in patients with diabetes, because patients with diabetes as compared to general population, they have a higher event rate of cardiovascular events. So statins are indicated in patients of diabetes irrespective of their LDL cholesterol levels, and the patient are in 40 to 75 years of age group, to prevent their absolute number of events from happening. Another population group is the pure primary prevention population, that is 40 to 75 years of age, who are walking into your OPD and they are telling, should I take statin or not? So these people, what you have to do is calculate a 10-year ASCVD risk. There are online calculators which help you in predicting a future 10-year atherosclerotic vascular risk event for that particular patient. So this is a chart which is showing primary prevention across the different population. So the first and the second population of diabetes and the LDL cholesterol of greater than 190 I have already discussed, and the chart shows that by calculating the patient's 10-year atherosclerotic coronary vascular disease risk, we classify them again into low risk, borderline risk, intermediate risk and high risk. Now low risk is if the event rate is less than 5%. Here you can emphasize on healthy lifestyle, and statins are not indicated. If the patient risk is borderline 5 to 7.5%, we can discuss the risk, we can look for some risk enhancers, and if they are present, may consider starting with moderate intensity statin therapy. Now, if the risk is greater than 7.5, then there is indication to start statin right away. However, if the patient is apprehensive of not taking statin therapy, then you may consider him for a coronary calcium scoring, so that if the coronary calcium score turns out to be 0, then it's you may go on and say that yes, statins, you may go up without taking statins also if the coronary calcium score is 0. However, as such, if the patient's risk is intermediate, you can definitely go on and start with the moderate intensity statin upfront. And if the risk is greater than 20%, they are into high risk category, and here you have to discuss with the patient to reduce the LDL cholesterol by greater than 50%. So you have to actually initiate high intensity statin therapy. So in the patients has borderline risk like 5 to 7.5%, and you are going to discuss with the patient whether to start or not. You have some risk enhancers. Now, this risk enhancers is if the patient has a family history of premature events, if there is a persistently very high LDL cholesterol levels ranging from greater than 160, if the patient is having metabolic syndrome, if there is chronic kidney disease, then there are some biomarkers like persistently elevated triglyceride levels of greater than 175. If the HSCRP levels is greater than 2, lipoprotein little a levels are greater than 50, apolipoprotein B is greater than 130. So these are all the risk enhancers. In a way, you can look for them in these borderline risk group patients and say that yes, if any one or two of these categories risk enhancers are present, they may definitely go on and take statin therapy. Then there are some risk for the diabetic patients where you can even go and tell them to take high intensity statin therapy if there is long standing diabetes, if there is albuminuria, if the GFR is less than 60, and if there is retinopathy or neuropathy associated with diabetes, because these are high risk conditions. Again, the risk enhancing conditions which I already discussed as outlined in this table. Now, what about hypertriglyceridemia? So, for any age group, if the patient is having hypertriglyceridemia, you always look for secondary factors why this hypertriglyceridemia is present in the patient, and you have to look for lifestyle factors like obesity, metabolic syndrome, diabetes, hypothyroidism, nephrotic syndrome, and look for the medicines which increase hypertriglyceridemia. If in 40 to 75 years of age there is hypertriglyceridemia, you calculate the ASCVD risk, and if the risk turns out to be 7.5 or higher, you generally initiate a statin as the first line therapy. But if there is severe hypertriglyceridemia such that fasting cholesterol is a range of more than 500 or even say more than 1000, then you have to prevent acute pancreatitis, because that's the effect which hypertriglyceridemia of these levels can cause. So here you need to focus on triglyceride reducing medicines. Here we have omega-3 fatty acids, and also definitely you have to think of go for low fat diet and avoid refined carbohydrates and alcohol, and even fibrates can be thought of at this point if the triglycerides are greater than 1000. Now, there are some issues with statins and women, particularly in the childbearing age group, such that pregnant woman, if the patient is planning pregnancy, you should stop statin at least 1 or 2 months before pregnancy is attempted, and if they are pregnant while on statin, you should definitely stop as soon as the pregnancy is discovered. In patients with CKD, the 10-year atherosclerotic coronary vascular disease risk of 7.5 or higher, and the patient is not on dialysis, and it's a risk enhancer as I already mentioned, and they should definitely have a moderate intensity statin, or moderate intensity statin combined with ezetimibe can be very useful. However, in patients with advanced kidney disease who are dialysis requirement, upfront initiation of statin may not be recommended. So, a few points about statin intolerance. These so-called statin associated muscle symptoms. Now, these are frequently reported in observational studies. These are perhaps a nocebo effect, Placebo-controlled randomized trials have shown this statin-associated true intolerance is very, very rare. So, what if some myalgias or some aches happen? What you can do is try reducing the dose of statin first. If it's not controlled by it, you can try changing the statin. If it still not goes, you can think of adding ezetimibe. And these are the 3-4 approaches where we can, you can always try to, so that your patients receive some form of statin therapy or a lipid lowering therapy. So even in guidelines, it does state that in the patient who has statin associated side effects that are not very severe, you can reassess and try to re-challenge to achieve the maximum LDL lowering effect. An alternate statin can be tried, a modified dosing can be tried, or it can be used in combination with ezetimibe. So these are the statin associated muscle symptoms, which include myalgias. Now there are some predisposing factors like age, female sex, a lower body mass, Asian ancestry, excessive alcohol, high levels of physical activity. Myalgias have been reported more among the patients with these predisposing factors. Myositis, it's extremely rare. Rhabdomyolysis is extremely rare. Then there is statin associated autoimmune myopathy, which is extremely rare. Now there are some issues of new onset diabetes, especially in the patients who have metabolic syndrome or who are on high intensity statin, but the risk benefit ratio does show that giving statin in diabetic patients or wherever it's indicated, it's always greater benefit rather than risk. So it's always advisable to give statin to the patients wherever it is indicated. There are some another side effects like liver transaminase elevation of greater than 3. It's very infrequent. Hepatic failure is very, very rare. Cognition, memory, it's absolutely unclear, and I think it's some case reports but no definite evidence. So here we come to our last slide, that in secondary prevention, initially they told that the high is bad, average is not good, then they found that the lower is better, then they found that even lower is better, and now they say that the lowest is the best. Thank you.